Why would a skull-based neurosurgeon operate on an intramedullary spinal cord tumor? Because these cases demand the purest form of microsurgery. Ependymomas offer a unique opportunity to apply skull-based principles: sharp dissection, arachnoid preservation, and atraumatic handling of the tissue within the spinal cord. This is an adult patient presenting with a 1 year history of progressive bilateral hand numbness and loss of dexterity. He also reports gait instability, and the neuroexam revealed focal left upper extremity weakness, a marked sensory deficit on the left side, hyperreflexia, and a spastic gait. MRI demonstrates a well-defined expansile intramedullary lesion at the cervical level. On T2 weighted imaging, the lesion is hyperintense, cystic, and well demarcated with a peripheral hypointense rim of hemosiderin. Post-contrast sequence shows uniform enhancement of the solid component. Here in the axial views, we can see that the MRI revealed a central solid nodule surrounded by a cystic hemorrhagic cavity, features characteristic of ependymoma. Due to the patient progressive symptoms, we recommended microsurgical resection. So the patient is positioned prone with the head in a neutral position using a Mayfield head clamp. Shoulders and hip rolls provide stability, or alternatively, a Jackson table can be used for support. The skin is incised over the C6 and T2 spinous processes, followed by fascial opening using the electrocautery. And then superiosteal dissection exposes the C6 to T2 laminate. At this point, just a standard laminectomy is then performed using a high-speed drill and Kerrison from gear. We always try to remove the lamina in one block to minimize the traction and manipulation of the spinal cord. Once the dura is exposed, a grid electrode is gently slid beneath the caudal lamina and placed epidurally for deep wave monitoring. Once the electrode is in place, we use ultrasound to delimit the margins of the tumor. The dura is incised sharply using a arachnoid knife. Four neural sutures are used to provide gentle traction on the dura for the cord to be exposed. The initial intradural view reveals this midline and solder bolts over the tumor. A monopolar stimulator at low milliamp is used to localize the posterior medial sulcus between both dorsal columns. PI is coagulated with bipolar at a very low setting at this point and incised sharply. Vascular forceps are used to extend PI incision over the margins of the tumor, and a Yusef-4 dissector is used to create a plane between the dorsal columns and the tumor itself. Now, 6-0 nylon stitches are used to traction the PI gently and laterally to avoid manipulation. Vascular clips are applied to tack the PI against the dura. Now the process is repeated in the contralateral side. It's important to note that we feel it's more efficient and safer to the patient to warrant continuous and mild retraction rather than repeating contusion during dissection. Incision over the posterior medial sulcus needs to be extended beyond the superior and inferior tumor margins to minimize retraction. We use contratraction with a small cottonite as we proceed with a sharp dissection. See how the blunt dissection is kept to a minimum to avoid tissue laceration and further manipulation of the viable tissue from the spinal cord. Here in this area where we can see the blood clot, it's more difficult to proceed with a sharp dissection as the tissue is more sticky to the spinal cord. For that reason, we divide the tumor in two pieces to proceed with a safer way of dissection. Preserving the tumor capsule is key to ease clean dissection. Maneuvers of contraction by the assistant help reduce the manipulation of the core when the cotonic technique or traction with P stitches are insufficient. Finally, when we reach the back of the tumor, see how the assistant is pulling the tumor upward and is gently irrigating to clean the surgical field. Now, just sharp dissection with a curved stitches, use of Penfield or a Joseph number 4 is usually enough to achieve hemostasis without the need of using any bipolar or cauterization of the tissue. Finally, the last attachment of the tumor to the spinal cord are carried down with the use of the assistant again and the contraction cotonoid technique. See how the blood loss is minimal as the tumor creates this film around its capsule that keeps intact from the surrounding spinal cord. Finally, we have this small remnant of the tumor and hematoma that was left behind to reduce manipulation of the tumor in a prior stage, and then in the same way use a contraction technique with the cotonite, the PA retractable stitches, and the use of assistant, we're able to achieve cross-total resection. We irrigate the field with warm saline to achieve hemostasis. We don't use any bipolar at this point. And finally, we approximate the PIA to close the myelotomy with 6/0 nylon stitches. We use interactive stitches to reduce ischemia of the tissue and the PIA around the areas of higher tension. Finally, the dura is going to be closed in a watertight fashion using running for neuro sutures. In this case, we are closing with 6/0 nylon. The patient did well with improvement on the strength on the left side. Left upper extremity was also improved in the numbness sensation, and the patient regained the ability to walk without difficulties. MRI shows gross total resection of the tumor, and the patient is still tumor-free at 3 years follow-up. Low-grade ependymomas are slow-growing tumors. If you preserve the tumor capsule, you're going to be able to obtain better control of the surgical field and maximize the chances to obtain surgical resection. Key for a safe resection is avoid use of bipolar, use of warm saline for hemostasis, and create this sharp and avascular dissection to preserve the spinal cord tissue. The ergonomics are key. Sometimes you need an assistant for these cases. Usually we prefer to place the microscope on between both surgeons to aid the surgery using 4 hands. Finally, the PL stitches retraction allows for a gentle and controlled exposure. I hope you like this video. Please do not hesitate to give a thumbs up if you like it, or share with your colleagues if you think it can provide some value to the community. Thank you.